Hey, what's up, everybody? I'm Maggie Reichard, pronouns she, her, and you are listening to Nursing Uncharted, the podcast that delves into all different types of nursing. Thank you so much for listening today. If you're a new listener, welcome to our channel, to wherever platforms you're listening or watching from. So glad that you found us. And welcome back to our old listeners, wherever you're listening. We are on YouTube at Nursing Uncharted, so please subscribe to our channel if you like watching the episodes. Or if you found us on Apple Podcasts, please leave us a 5-star review. We're on Spotify and Instagram as well at AMN Nurse. This episode is sponsored by AMN Passport. AMN Passport is an app that AMN has created. It's travel healthcare's highest rated mobile app, and helps you find assignments, book assignments, and manage everything all from your phone. You receive instant job match notifications when you download AMN Passport today. So this episode is all about military nursing. Last year, we had a wonderful friend of mine come on to give us the ins and outs of military nursing. And today we're expanding on that conversation, getting some insight on the benefits of military nursing, what it's like to be deployed, and some of the real, stories of a military nurse. And we're doing that with my good friend, Corrine Gogert. So Corrine is a major in the United States Army, and she is currently attending school to earn her DNP for acute care nurse practitioner and clinical nurse specialist. It's a dual program. She's been an Army nurse for 11 years, and she's been stationed all over the U.S. with one deployment to Afghanistan. She's served in med-surg, pediatric, old adult ICUs, with some time as nurse management and in education as well. So Corrine, welcome to the show.
Thanks for having me. I'm really excited to be able to have this conversation and just kind of open some people's eyes to military nursing and what it's all about.
Yeah, absolutely. And I mean, I come from a family that don't have any military people in my family, and so it's always really interesting to hear that side of not just nursing, but just what it's like to be in the military as well. So I love.
What makes you feel better? I never thought that I would join the military.
Really?
And then when I did, I was like, I'm doing 4 years and then I'm getting out. And here I am 11 years later, still in and still doing what I love. So,
well, there's a lot of, so what made you kind of change or stay?
Honestly, it was the experience that I was able to gain while in the military. So in my first 4 years, I actually had my deployment to Afghanistan, which really opened my eyes to what military nursing can really be and some of the things that we get to do that are not just your everyday nursing. Not that everyday nursing is boring. I mean, it's a new thing pretty much every day, but having that experience going to Afghanistan and kind of seeing what else we can do, what else was out there that was unique to being in the military was really eye-opening. And getting to meet people. I get to meet people from all over the world. I get to be stationed with people that I would have never met elsewise. So it's been a great experience.
Do you, as a military nurse, are you taught do they expect you ever to be a part of combat, or do you mostly just stay on the medical side? Obviously you're taught, with training, but are you ever expected to go on to the combat side?
Not unless you go through more specialized training. There are opportunities to be embedded with Ranger battalions or special forces teams, but that requires special training. You have to be selected and go through a whole process. But generally speaking, we stay in the treatment facilities, but those can be, within miles of the front line, if you will. Right now, we don't really have a front line like it used to be in World War II. But yeah, we can be right in the mix of it. My deployment, we got indirect fire at least every day, if not more than once a day.
What does that mean, indirect fire?
Oh, so basically it's, if you've ever heard of rocket propelled grenades or artillery, stuff like that. So basically they're further away from the base with their artillery, and they'll just basically lob explosives from multiple miles away, hoping to hit something. So it's pretty common in Iraq and Afghanistan to be hit by what we call IDF or indirect fire. And sometimes it's accurate and sometimes it's not. So it's just kind of It's literally a hit or miss situation.
Yeah, right. Oh my gosh. And like every day, that's happening just every day.
There were times like during Ramadan, it's a little bit more prevalent because they have to do it before the sun comes up, just based off of
Oh, wow.
Islam and how Ramadan works with the fasting. They don't typically want to hike, 20 miles up while they're fasting. So that was our alarm clock most mornings during Ramadan. About 4 a.m. we would just wake up to the indirect fire alarms. And you probably have seen some videos on like social media. Sometimes they'll pop up of the alarms like incoming, 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 rah, rah, rah.
Hmm.
And so that's what you get to wake up to at 4 a.m.
That is
Um,
wild.
so yeah, we only had two times where it came pretty close, but nothing that actually was able to cause any real injury to any of us or the allied forces
That's
that we were
good.
with.
What's like
Yeah.
the protocol when those things go off? Like, do you have to go to like designated areas or?
The army answer is yes. After about 3 months or so,
Yeah.
you kind of get really tired of it, and you're like,
Yeah.
I could,
It's like
or I could
fire
just stay
alarms
in
in the
bed.
hospital. Yeah. That's like the
Yeah,
fire alarm, like, and you like have to like
gotta get.
shut all the doors. It's like nobody
Yep.
thinks it's like a real fire.
Yeah, exactly. It's very similar. Like you just get really, like I guess overwhelmed after a while, and you're just like, you know what? If today's my day, then today's my day. At least I'm gonna die comfortably in
Right.
bed.
Like, I'm good. I'm just gonna roulette it and I'm just gonna stay in bed.
Just gonna see what happens.
Yeah.
Yeah.
So tell me some of the reasons why people choose military nursing in the first place. Like, what are some of the benefits that military nursing offers?
So really a lot of the reason and like the reason that I joined initially was to pay for school. So
Mm,
you can do the Reserve Officer Training Corps, which a lot of people have probably seen their ROTC
yeah.
battalions in their universities. So that's one way. While you're getting your bachelor's degree, you can join. You'll commission right as you graduate, and you can go into the reserves or active duty depending on kind of your situation. And they'll pay for school. For me, they paid for 2 of the 4 years. So it was less student debt for me,
Yeah.
which is always a plus.
Yeah.
Um, but they also offer a lot of really awesome opportunities, education wise. So once you graduate, once you have your bachelor's, and I'm strictly speaking for the officer side,
Mm,
not the enlisted side. A lot of people enlist into the military for thousands of reasons. But once you get your bachelor's degree, you can do what we call direct commission. So you don't go through any kind of um, military training beforehand. All you do is you'll commission in as a second lieutenant. And then you'll go through, like, depending on your section, like if you go into the medical department or if you go into infantry or whatever, you'll go through specific training for that. But it's a much shortened version.
mm.
And then you'll just join as a second lieutenant, and then they can do student loan repayment. So if you already have student loans, then they'll actually repay those loans based on how many years you sign up for.
Okay. And
So
does the amount of loan forgiveness depend on the amount of, like, are there different contracts? Like, I'm going to stay in the military for X amount of years, or is it like you have to be in the military for 10 years in order for like loan forgiveness?
no, it's actually really the minimum is 4 years
Mm,
that you'll do. So they'll say, hey, you got to join for 4 years, and we'll pay back. Depending on what you're repaying. So if it's like a bachelor's degree, it's usually 4 years.
okay.
And they'll repay back all of your student loans. But
Amazing.
then after those 4 years, you can either get out and you join what's called the inactive ready reserve, which is a list of people that are still on on duty, but they're not you don't have to do anything military related. It's just in the event that something terrible happens, they're the first people that we call up instead of doing a draft. We call up the IRR, the inactive ready reserve.
Mm,
But you don't have to do anything military related.
okay.
But generally, it's 4 years of active time and then 4 years of IRR, and that's it. And then you have your bachelor's degree paid for.
Amazing. And
Yeah. So
and like there are other federal programs from the Department of Defense, right? Like there's, I mean, like we were talking before about like CRNA programs or FNP programs as well.
yeah. So once you are in the military, then you can apply to these programs through the Uniformed Services University of the Health Sciences. We call that USHUS for short because that's a lot.
You shoes.
Um, and and that's the DoD's or the Uniformed Services. Basically, it's like their medical school. So they do medical school for um, MDs. They have doctorate programs for nurse practitioners, for clinical nurse specialists. They have anything kind of health services related. They have a schooling for that. So you can apply to that university, and then you'll be spending time as an active duty service member while going to school.
Mm,
And it doesn't cost you anything. The government, it's all paid for. And then you just owe them based off of how long the schooling is. So for like a DNP is 3 years.
mm,
So after 3 years, then you owe 5 years to the military after you graduate.
okay.
So there's that. And then you can also apply for the Certified Registered Nurse of Anesthesia CRNA program. And they actually have a couple of different programs that you can do. One of the biggest ones is through Baylor University, Texas. And that's through the U.S. Army Graduate Program in Anesthesia Nursing. And once you graduate from that, again, that's 3 years. You owe the Army 5 years after that.
Mm,
So really anything that you want to do, you can do it. You have to meet certain requirements. Like you go through a selection process. Like you have to have decent grades and you have to do the GRE and you have to get a certain score on that. And you
mm,
have to have good enough evaluations from and like letters of recommendation. But once you get through all of that, like you can get into the program and basically, I mean, by the time I'm done, the Army will have paid for half of my bachelor's degree, two master's degrees, and a doctorate.
that's,
And it's all, I mean, I'd say free, but it's all through the military and I didn't
yeah,
have to pay anything out of pocket.
that's amazing. So is that what you're
Yeah.
doing right now? Like, you're in school at a federal program or is it like contracted out like to go to a university school like that works with the military? Or like are there two
Kind of.
different like yeah,
There's
explain that to me.
there's two different paths. So what I'm doing is a program called Long-Term Health Education and Training. I applied for that, submitted all my documentation, and they gave me the blessing saying, "Hey, you're a good enough Army officer. You have good enough reviews and grades and GRE scores, so you can do this program. What would you like to specialize in?" And I said, "Well, I'd like to get my doctorate of nursing in clinical nurse specialist." And so being as I was an ICU nurse before, so that's a whole nother program that I had to go through. In order to become specialized, you have to go through programs and trainings
Mhm.
with the military to get that, what we call an identifier. So I
Mm,
was an ICU nurse before I applied for the program. So I'll be a critical care or acute care clinical nurse specialist.
okay.
And that program is not offered at the Uniform Services
I
University.
see. Okay.
So I had to go through school, what they call school of choice. So you can apply to any school that has that program as long as it meets their tuition cap. Um,
Hmm.
and they meet like certain guideline requirements. Like it has to be accredited. It can't just be like an online program. And so I was able to apply to a bunch of different places, got into some places, decided which one I wanted to go to. And so now I'm still on active duty, but I don't have any active duty requirements other than my physical fitness test that I have to take every 6 months and then my weigh-ins every 6 months. But I don't drill. I don't have to do anything with the military. I have my required training, but it's all done over distance. So
Hmm.
for 3 years, I get to go to a civilian university, spend time, just learning. And then once I graduate, I'll go back into what's like the more traditional active duty time.
I see. Okay. And then
Yeah.
after you're finished with schooling, do you have is it 5 more years or you've already used that time?
No, it'll be 5 more years.
Okay.
after I graduate that I owe. And that'll put me right about 18 and a half, 19 years. So I'll do one more year and then retire at 20 years.
That's crazy. Oh,
I know.
can you imagine? I mean, yeah, like then you're
Yeah.
done.
Retired at 43, will be kind of where I'm at. So that's full retirement. I'll get a pension from that, and whatever the Army decides, however much they broke me will determine how much disability pay I get.
Oh gosh.
So
Yeah. I guess that's a benefit, right? Right.
it is, and that's not many. I mean, I can't think of really any other besides like government service jobs that where you can be retired at 43. Like that's unheard of.
Yeah.
So, and I mean,
That's
granted, that's
amazing.
not something that you could live on anymore. It used to be something that you can, but
Mhm.
I'll have a doctorate degree. I can go do pretty much whatever I want with it. I could stay in the
Right.
military if I wanted to. There's people that have, served 35 years. But it's not something I see myself doing.
Yeah.
I don't have an aspiration of being a general someday.
You're like,
So,
do my 20 and get out.
well, I mean, it's better than doing my 4 and getting out, which is what I thought it was going to
Yeah, right.
do. So,
So I wanted to get in kind of some of the different specialties that you can get into in the military, like within nursing. I know that you've kind of bopped around to a few different specialties. So like what do military hospitals look like as far as like set up, different units, and then how do you like identify, do you have to identify as like a med surg nurse or an ICU nurse, or like how does that work? Like do they float you around?
yeah, so a lot of that is really similar to civilian nursing.
Mm-hmm.
Especially when you're military, because they kind of see us as like this workforce that can go anywhere. Like we are exposed to a lot of different things. So we do float all the time. But as far as specialties go, so everyone that comes in, unless you have prior time as a specialist or specialty. So like if you had 5 years of ICU nursing, and then you decided to join the military as a direct commission, meaning you didn't go through ROTC, then they would automatically just put you with an identifier as a critical care nurse.
Mm-hmm.
But if you go the traditional route through ROTC and commission as a brand new nurse, you get your RN, and then you go to your first duty station. You do 6 months of orientation time,
Mm-hmm.
and then you enter as a med surg nurse. That's where everyone starts out as. We all start out as med surg nurses, and then you have to get at least 1 to 2 years of time as a med surg nurse before you can apply to go get a specialty identifier. So you can be a labor and delivery nurse. So that's a program that's taught at Fort Hood, Texas. So you can go through that, and then once you're done with that, you'll be identified as a labor and delivery nurse, which is its very own unique specialty, which I have no desire to go to.
But you have to nurses. Like move to a different base in order to do a certain specialty?
Yeah, so it depends. Most of those are not very long courses, so they're usually less than 6 months of a course. So they don't move you permanently there.
Okay.
So you'll basically live there for 6 months, do the course, and then the Army will move you to wherever they see is necessary. So, if there's a ton of need at Fort Hood, Texas for labor and delivery nurses, which there generally are, you could just go to the course and then stay there, or you might go to any number of the different bases across the country.
Right. Okay.
And then, so you can do labor and delivery nurse, you can do OR nursing as a specialty, that's taught at Fort Sam Houston and San Antonio. You can be a psych nurse. So if you wanted to do like inpatient behavioral health or specialize in behavioral health nursing, and then you can also do critical care nursing and ER nursing, and that course is combined. The clinical time is split up, but the didactic portion of it is all the same, and that's what I did.
Okay.
So when I came back from Afghanistan, I realized that I really enjoyed working in the ICU there, and decided that I wanted to go to critical care. So I applied, and then it's a 16-week course, 18-week course, in San Antonio. And you go through 10 weeks of didactic, and then 8 weeks of clinical. And then once you finish that and graduated, then you can call yourself a critical care nurse or ICU nurse or ER nurse. So there's
Gotcha.
all kinds of different specialties depending on, what you want to get into, but you don't have to specialize either.
Yeah.
There's, you can stay a med surg nurse. There are a ton of med surg nurses that are, full bird colonels and beyond, that are wildly successful. And they just decided that they wanted to keep their options open so they can kind of go wherever.
Yeah.
But in order to be stationed in like an ICU or to be deployed as an ICU nurse or an ER nurse, you technically have to have that identifier.
When different hospitals are set up different ways, where like sometimes there's just like a general med surg floor, and then sometimes there's like a cardiac floor, a GI floor, a neuro floor. Like, how are military hospitals set up? Are they large enough to be kind of like in these subspecialties, or is it normally just generally pooled into med surg?
So it depends on the base.
Okay.
We have two kind of styles of hospitals, or what we call military treatment facilities. In the Army, at least, the Navy hospitals have a little bit different. But so we have what we call med cents or medical centers, and these are the big hospitals. So this is, if you've ever heard of like the burn unit in Fort Sam or SAMC, BAMC, that is our like flagship hospital. That's probably it is the biggest hospital that we have. And they have, upwards of 20 inpatient units. It's huge.
Oh, wow.
So they have all kinds of different specialties. So you could go to a medical floor, you can go to a surgical floor, you could go to the neuro floor. They have 8 different ICUs. So like all of their stuff is very specialized.
Okay.
But then you also have MedAC, which is medical Army community hospitals. And those are smaller and they tend to have less specialties. And they're more just focusing on like your basics. So you'll have like an inpatient medical surgical ward, an inpatient ICU, inpatient psych, but they're not delineated. So one of my facilities at Fort Hood, when I first started, it was medical surgical, tele, peds, all on one floor.
Yeah.
We called it the family care ward. And so it's like everything.
Yeah.
So it depends on where you go, basically, is the answer to that.
Yeah, that makes sense. Yeah, it's just like civilian hospitals, same thing, it's all roped in. I want to go into deployment nursing and what Afghanistan was like, because it's just a topic that we didn't really get to go into in our last episode. So tell me a little bit about day in the life as a deployed nurse and what it's like to be deployed, especially in Afghanistan.
Yeah, so I deployed in 2014, so it's a little different than it is now.
Sure.
But when you get there and it's like 3 days straight of flying, you fly from the States through Germany and Kuwait, and it's just a whirlwind. So after about, I think, 78 hours of flying, we finally got to where we were going, which was in itself is just exhausting. So like you don't know what time zone you're in, and you've been flying for 3 days, and you're just like, oh my gosh. And so once you kind of get into the routine, generally speaking, there's no real schedule. It's not like, oh, you're working 3 on, 2 off. Generally speaking, unless you're at like a really big hospital. So the one at Bagram Airfield was really big. And then there was one at Bastion that was British run, but we served there as well. And they actually had schedules. So you would work, a certain amount of days, and then you'd actually be off for a couple of days. But I was in a smaller facility. So we just you just worked all the time. So you would be on pretty much 7 days a week. And depending on your patient
work 7
load.
days a week, or you would be on call?
No, so you would work.
Oh, man.
It was kind of hit or miss though, because we wouldn't always have patients. If we hadn't had a lot of combat going on, or if we, there weren't people. We did a lot of really routine surgeries too. A lot of appendectomies.
Hmm.
So we had routine surgeries like that too, but we didn't always have patients. So if we didn't have patients, we would just be around, and then you'd have a pager on, and then if a trauma came in, then you get called in.
Okay.
But it was very much like work when you have to, sleep when you're not kind of thing.
Mm.
Um, and so you never really knew. And so and you didn't really have like a day shift and a night shift. You had the shift that you normally would work, but if there was a trauma at 3 a.m., or if there was like a mass casualty situation, everybody, everybody got called in. So your pager would go
Wow.
off and everybody would just run in. And so typically speaking, we served pretty much everyone. We were on a multinational base, so I actually got to work with providers and teams from the Czech Republic, from France, Bulgaria, and Jordan. So that was really
Wow.
fun.
So like the
So
nurse
you got to
next to
kind of
you
see.
could be like speaking a different language than you?
Mhm. Yeah, and I mean, a lot of them spoke at least general English.
Okay.
But if they were working within their teams, like each nationality had like their own team. Really, they would have like doctors and nurses and aides and techs and stuff. But yeah, so like in the trauma, a lot of times they would keep those teams together. And so like you'd be working on somebody and there'd be somebody yelling in Bulgarian next to you. I really hope that they're okay because I don't know what they're saying.
Would they like
Um,
how were you ever in a situation where like somebody above you, like a physician or something, was trying to give you orders in like a different language and you were like trying to
oh
like
no, like if they were working with us or trying to actually communicate to us, they would speak English.
okay.
And so it did. I did work with those other teams in trauma. But generally, if they were working with other countries, we all just defaulted to English.
Yeah.
But it was great. So like I got to learn all kinds of different like phrases. Like I, got to learn a little bit of French. I got to learn a little bit of German because the guards there were German.
Hmm.
A little bit of Arabic. So you got to learn like a lot, which was cool. So generally speaking, like day to day, if we had patients, I was a medical surgical nurse when I deployed. So I would show up to work. We do shift report just like, a normal hospital. You get report from the night nurse and say like, hey, this is what's going on.
Mm-hmm.
Here's what's planned. And then if it was just a calm day and there wasn't any chaos going on, you would do your shift. You'd have everything was on paper charts. We didn't
Mm.
have
Okay.
electronic charting there. And so you would just, you would give your meds, you would talk to the doctors, they'd round, and then you'd kind of go on about your day.
Mm.
But that wasn't always the case. And so, we'd get like a trauma call in, and depending on how many people were coming in, we'd leave some people back on the ward to watch the patient. So we usually
Sure.
you'd have at least one or two nurses that would stay back, watch the patients that we have, and then everyone else would be in the trauma bay getting ready to receive
Mm.
those patients.
How many people
So
would
yeah.
you have like do you remember how many patients total you had like all at once?
I'm trying to think. I think the most we had was when we first started. Um, we had a lot of local nationals, so a lot of Afghani
Mm.
patients, and there was probably about 15 of those, and then we would have on average like say like 5 to 6 either US or allied forces.
Mm.
So on average about 20 patients or so.
Okay. But then how many would you have like personally if there was 20 or so people on the unit?
Um we tried to keep it to like generally what we would do in the States,
Okay.
like 6 to 7. But it kind of depended on, we usually only had 2 people on the ward, I guess, if you want to call it that, at a time. So it was just whoever you'd split it up between the two of you, and you just kind of make do with whatever you had.
Gosh, I've never had 7. I've had 6 like on nights or something, but I mean, I know that those ratios are out there, but do you feel like was 7 a lot like when you were or do you feel like it was kind of manageable?
It's different care there. It's very
Yeah.
much like, kind of get the basics done. A
Mhm.
lot of these, the local nationals would stay with us for a while. until we could get them either out to the Afghani hospitals or to go home. But it was really kind of basic stuff. We weren't, it's not like we're taking them to go do swallow studies or x-rays or anything it's very basic kind of stuff.
Yeah.
So it was pretty manageable. The traumas are what really threw you in for a look, because, it doesn't matter what specialty you are, you get on shift and you're like, okay, this is how I'm going to plan my day. You have like all your meds timed out and everything. And then they're
it
like,
all
oh,
goes out
okay,
the window.
Yeah. So you're like, okay, well, here we go. So everyone gets really great care, but it's just a little different.
Sure.
There's a lot less, you don't have all these different things going on. You don't have like all these initiatives that you're trying to like manage and
right. Yeah.
So it's just different.
I do feel like, when we think about nursing, and I can't really speak to this because I didn't work in nursing 30 years ago, but like when you hear about ratios from 30 years ago, it seems like, it's like one nurse had 15 patients. And in my head, I'm like, how did you ever? I would be so like, so over this. But I think like it was a simpler time, it seems like, or like the expectation on the nurse was like a little less like, there weren't all these like quality initiatives and it was like paper charting. And like, I think the expectation may have been like just a little bit more relaxed, I think, than where we are now. I wonder if there's like similarities there with the military nursing, like the paper charting.
We go back in 30 years.
Well, no, but like, as a deployed nurse, it's like, okay, it's like you've built this base and everything is kind of like forming as you're like in real time. I feel like there's got to be a little bit more of like understanding for the nurses, like that, you're not going to be able to like chart your fall risk indicators or, like what, all the things that we have to do over here.
No, it's very true. Like, there's a note for like your progress note, and then there's the medication administration record. There wasn't really a whole lot, and like nursing treatment. So like if you had to do a dressing change or wound care, whatever it was. But yeah, there wasn't like, this like 17-page Johns Hopkins fall assessment and, their pressure, ulcer risk, anything like that. Like you give your meds, you treat them with whatever they need, and that's it. You're not writing these, really super in-depth nursing narrative notes, or you're not taking them for random studies and stuff like that. So
gotcha.
it's 100% just simplified. Less, I guess, less total. Yeah,
for sure. Do you see a difference in working or any like glaring differences between working at like a trauma unit here versus a trauma unit as a deployed nurse? I guess we already we kind of talked about like the different teams and everything, but
right. Honestly, it is. It's very different. It's so much more calm. I've done quite a bit of time in trauma. Yeah, in trauma units here. And the doctors that you deploy with, our trauma doc, I could not say more good things about him. He just is fantastic. And anytime it got to the point where he couldn't hear which each individual bed was talking about, he would immediately just yell super loud, get everybody calmed down, and he'd be like, everybody shut up, normal talking voices, and then you would go about. And you could hear a pin drop at some points during these mass casualty situations. And it was amazing to see how well everybody could work together. Obviously there are crazy times, like there was a point where I was running a code and I'm like having to yell to get things because I only had, it was like me and one other person, and so I'm yelling to get other stuff, like other people to get over there, and it does get a little chaotic, but I'd say 99% of the time it is very calm. It's very organized. We rehearse this all the time, so even if we're not in a mass casualty situation, we get fake patients, and then we run through it like, okay, this is where you're going to be. And in triage, this is what's going to happen. And then this person's going to talk to this person. And you just run through it, and you run through it with people in different roles. So that way it doesn't matter who's there. You still just know, like, this is what I'm going to do. And this is, the role of the person that I'm talking to. As the nurse, I'm talking to the doc at the head of my bed. And then that doc is talking to the trauma king or trauma queen, whoever's, in charge of the trauma bay that day. So it just went super, super smooth,
Wow.
which when I came back stateside, I was like,
there's a lot.
So
there's a lot going on.
What's going on? What's going on? But no, I mean,
That's
and not
amazing.
in a bad way. It's just different. But yeah, you just rehearse it, day in and day out. And I think, like, these are your brothers and sisters, that could be you on the table. And so you just treat it. It's almost like you don't treat them any different than you would civilians, but it does feel like there's higher stakes.
For sure.
When it's, somebody that was out there, trying to save your butt. So yeah, it does get difficult. There was one mass casualty, where it was some of our own. It wasn't the medical folks, but it was people from our base that had just been with us the day before, and they got hit by a vehicle IED. And we were working on people that had just been in there handing out challenge coins and just laughing and joking with us, not even 24 hours before. And that was hard. We ended up having to like crack a chest on somebody that we knew really well. And that was hard. Those were the times that, people talk about that kind of stick with you.
Yeah.
And so those are the higher stakes, and that's when it got really real, really quick. But
how long had you been there?
So it was probably about 6 months in, to us being there. So yeah, we left not too long after that. I was there for about 9 months.
Okay.
And yeah, so obviously can't talk about like the details of what it was or anything, but it was it's just really hard, when you're looking there and you're like, that person, like, I just shook this person's hand, and now you're having to say goodbye, and that's always tough. And it's tough for you, but you also know, I was deployed with kids. I say kids, they were 19, 20 years old, and they've never experienced like death like this. And so you're having to kind of like, because I mean, we all remember as nurses, like, our first patient death. It's something we all will probably always stick with us. And there are people there that they're not medical. We had patient administration specialists and lab, like people that weren't direct medical care that had just been talking with these individuals, and they're like, what do you mean they didn't make it? And you're like having to kind of walk them through that, and it's a totally different experience.
I can't imagine. I mean, my first patient death was like kind of like an end of life, we knew it was coming situation. I can't imagine it being like a mass casualty. It was like, it's hard to swallow just seeing somebody pass away, let alone like so traumatically. Do you feel like
they I mean, oh no, they grew up really, really quick. I had a different experience. I've been a nurse for about 3 years. By the time I had deployed, I'd already, seen that kind of stuff. But these are kids, I mean, and they just, they'd never seen anything like that. So they grow up really, really quick. And it just makes you feel for them.
Do you feel like the military, or at least where you were in your experience, do you feel like there are any kind of like coping strategies in place, like on a systemic level, like because you're exposed to so much when you're over there? Like, is there anything to help nurses or medical professionals kind of like process any of that?
Um, not, I guess not, um, like, strictly programs, I guess.
Yeah.
You get really close, to the people
Mm-hmm.
that you deploy with. So we would always have, like unit get-togethers and stuff at the end of the day. We'd barbecue all the time,
Mm.
and stuff, and we would just kind of be there for each other.
Yeah.
But then, and we have like, mental health professionals that are deployed with us that can serve both the patients and the people that are there. So, they have the support, absolutely. But a lot of it, it kind of waits, I guess, until you get back. And then you kind of seek behavioral health or, unfortunately some people don't. And they just kind of like live with it and it eats them away slowly um, but the military is really great with having those resources available. You can
Mm-hmm.
absolutely seek those out. It's obvious, it's free for us. All of our healthcare is free. We have basically socialized medicine and military, and so you don't have to worry about
Mm-hmm.
incurring costs because you've got PTSD from that kind of stuff. But I guess I don't know. A lot of critical care nurses, we have a dark sense of humor, and
Mm-hmm.
that just gets exponentiated in the military.
Yeah.
Sometimes the coping mechanisms aren't. A mental health professional would probably say dark humor is not a coping mechanism, but we definitely see it as
It is.
so.
Well, I guess it's a
Yeah,
way
so
I mean, lighten a kind of morose situation, right? Like we have
yeah.
it in the ICU as well. Like, you have to laugh about something. Sometimes you find like dark ways to laugh about things. And I don't know, it's kind of a way to connect to your other fellow ICU nurses in a weird way.
Yeah, it is. We become a family, so there's really not a whole lot that's off limits as far as dark humor things go. So we definitely imbibe in a little bit of that here and there. Just like anyone, but I feel like it's on a new level when you add the military mix to it because there's some people there that they've seen some stuff outside of medical stuff, and so then they bring that into the mix, and it just
Yeah.
it just gets a little wild.
I mean, that's like one nursing in general is just like a melting pot of different like backgrounds and staff and everything, and just like
It
adding
is.
the military in, and then it's like different countries. Like, it's just, you probably, I mean, you meet literally all walks of life there.
Yeah, yeah. It was. I mean, and obviously, like you can't drink when you're deployed.
Mm,
You can't drink alcohol, and so I think it's a good thing because I think a lot of people would probably turn to that.
yeah.
But there was all kinds of jokes about like, oh, if I could only have a beer right now, or whatever. But no, I think it's a really like in a way it's a really good place to experience trauma because it's about as close to somebody as you're gonna get. And there's no
Mm,
shame. Like if somebody says like, "Hey, listen, I'm having a really hard day," not a single person in that situation will judge you. Not that they would when you're back home either, but it's definitely more of a safer space for that kind of stuff.
people know what you're going through because they're going through it too, right next
Yeah,
to you. Yeah.
yeah, yeah.
Oh man.
But it was a good experience. So I mean, I 100% would do it again. And I tell people, if you get the opportunity to deploy, absolutely do it. It's an experience you won't get anywhere else.
Yeah.
And the things that I learned, I learned like all kinds of tips and tricks from people from other countries. We learned about different things that they can do, like different, like they have different, I guess, standards in different countries. So,
Sure.
nurses are able to do a little bit more in other countries. So, they were teaching us, here's our, the best way that we saw to insert chest tubes. And this is the best, the tricks that we use to intubate and stuff like that. So it was pretty cool to learn from
Yeah.
different countries
I
too.
know. I'm sure like when you're working with another team and like they do things so differently and you're like, okay, well, this is not something that I've ever done. I don't know if you want me to do this. I'm sure there's,
Yeah.
yeah.
Yeah. We ran into a couple of situations where like they have different like practice guidelines. So like, for closed head injuries, they have different algorithms that they use for treatment like that. And I'm like, that's not what we would do. I don't know if yours is better or worse.
It's just like a
But
comfort level thing.
it's
Like,
yeah. Like I don't everything that I've been taught tells me not to do what you just told me to do. So what do we do
give me
here?
an example like of like do you remember any situations you were in where like that happened?
Yes. So I won't say the country that it was, but I was working with a different country as a doctor. And we had a patient who had a closed head injury, and he was like, "I'd like you to give 5 of Versed," and I was like, "I
Mm.
don't want to do that, if I'm honest."
Like for intubation or
I
for
was
like just five, just
to keep him. Yep,
five of
just 5 of
Versed.
Versed.
Just slam that
Why
in.
not?
Okay.
So I was like, and I'm still a new nurse. I've been a nurse for 3 years. I'm a baby nurse, and I was
Yeah.
like, listen, like I don't know a whole lot, but I know that that's not great for your airway, and I know that's not great for closed head injury. Like we'd like to be able to assess them.
Yeah.
But he's like, he's in pain, and I'm like, yeah, I get that. I would be too. He's got a pretty
Like maybe
decent,
your Versed is not as strong as our Versed, but like I wouldn't push 5 of Versed.
it was just a really like awkward situation. So I was able, like, thankfully I was able to get the trauma doc, and I was like, hey, like this is what's going on, and then I was able to like kind of excuse myself from that situation, and the doc handled it, and they figured it out. But yeah, it was. And it's all about critical thinking. You want to talk about a crash course in critical thinking, get deployed.
Well, and that's really interesting because like there's already as a critical care nurse, I think you already have to have a lot of like background knowledge in medication administration, like what doses and how and stuff, and you are working with younger doctors that might not, have that same amount of experience yet. And it's always, kind of in the back of your mind, like making sure you're double checking with people. So you have that already. And then you have, the whole factor of they're coming from a different country that does all these different protocols. And so you're like, are they a new doctor or they're just a doctor from a different area that this is what they do all the time? Like, if you were working with another team, was there a way to like see what their normal protocols were, or it was really just like you were told by the team, like, this is how it's done, this is how we do this?
It was kind of more like on the go sort of situation. We would do like the doctors, for the most part, the provider level, they would meet together and say like, hey, this is what we agree on with certain situations, like if this then this, and they would all kind of get an agreement. But obviously you can't hit every single scenario that's going to come up, and that apparently just wasn't one of the scenarios that had come up yet. But when you have like a bigger hospital like that, a lot of times they come with just like regular civilian hospitals, you have like guidelines of, this is how things are done on this unit. And, that doesn't go away just because you're deployed. Like we still had like unit policies and what we called standard operating procedures of like, if you have a patient that's, out of surgery, like you have to do vital signs this frequent and, this stuff. Like we still have general guidelines. It's just not as strict. And there's not as many of them. So, but yeah, so there were some scenarios where that didn't always work out.
Yeah. What is some advice that you would give to some prospective nurses that are thinking about deploying, if there's, anything off the top of your head, like what's something that you wish you would have known, or advice that somebody would have given you coming out of it?
I mean, if for somebody that, that's, relatively new, honestly, I would talk to other people that had deployed. I had a relatively short notice. It was about a month from them saying, "Hey, we have this opportunity to deploy. Would you like to go?" To me actually being in country. So I would have really liked to have talked to somebody that had deployed and say like, "Hey, like what can I expect?" Obviously, every
Yeah.
deployment is different. It depends on where you're going to go. But, like what kind of things did you go through? What did you see? I never expected to be doing internal cardiac massage on somebody. That was not something that I saw myself doing ever, really. But there I was with my hand on somebody's heart, just pumping away and doing internal CPR. And I was like, that's not where I saw this day
Crazy.
going.
Yeah. I cannot.
So stuff
That's,
like that.
yeah. I'm not a cardiac ICU nurse, so I've just that would baffle me. I to ever do that.
I like the doc was just like, yep, nope, just put your hands at the apex, put your heels and your hands on the apex and just squeeze. And I was like, they don't teach you how to do this in ACLS.
It's not part of the skills check off.
It's not something we normally do.
Yeah.
But and then like I've never seen the internal defibrillator paddles used until that day. I was like, that's a thing. That's cool. Because I was a med surg nurse. We didn't. I later went into a cardiac ICU, but I didn't have that experience then. And I was like,
you did that as a med surg nurse?
Heart.
You did the cardiac massage as a med surg nurse? That even more so, that would freak me out. It's like, because there's less chaos, I feel like, in med surg, and then you get one of those.
Oh, yeah. No, I mean, like, it was 100% like, all right, float, swim, fly, whatever, do it. It's just like, and I was like, okay, cool. Let's do this. And like, after, like, I remember after I get done, because like we were switching out, like we, just like with normal CPR, you don't want somebody doing it too long.
Yeah.
I just remember standing there and I was just like looking at my hands like, what just happened?
Yeah.
And it took me a second before somebody was like, hey, we need you over here. And I was like, yeah, got it. Hold on. Sorry. Let me like, yeah. So it was bizarre. But yeah, like expectation management would have been great. Saying like, okay, hey, this is what your living conditions are going to look like. This is what, what it's going to, what your like normal day to day kind of stuff is like, what the crazy things that you might see, just so that way when it does happen, you don't have to be like, this is out of left field. You could be like, oh, okay, I kind of expected that this might happen.
Yeah. Yeah, I'm sure that you'd be able to process things with a little bit more clarity, I think, if you kind of knew what you were getting into.
Sorry, getting myself into yeah. I said that on the regular. I'm like, what did I agree to here?
Yeah.
But like there's we still have our fantasy football league from Afghanistan in 2014. We still have that league every year. And it has he's now retired, a full-bird colonel who was our pharmacist. We had a kid who was a specialist. He was like I think 20 years old. And we're all like grown up and we've got kids now and everything, and we still have the same fantasy football league every year, and it's an absolute dude.
That's awesome.
So it was fun. So you still I still keep in touch with darn near everybody that I deployed with, so that was fun.
Yeah, I know. I can't imagine how necessary I think that would be to be able to come home stateside and be able to like talk through all of the changes as you come back, to talk through all of that with the people that you deployed with. I'm sure that's so important.
Yeah, there's Yeah, I mean, it's similar to, like talking with, after a code with, the people that were there, or I mean, really just any other nurse that's been through that,
Yeah.
especially with like COVID, having that group of people that you could talk to and be like, yeah, this is what we experience. And you don't have to explain it. You don't
Yeah.
have to explain why you feel the way you feel, because they know they're feeling it too.
Yeah. Yeah, absolutely. Well,
But
I'm so glad that we got to talk about this today. This was a wealth of knowledge. I'm so happy that we were able to do this.
me too.
Well,
It's been great. I'm glad that, I don't, maybe it won't convince anybody to join the military, but, if somebody does, there are military recruiters everywhere. So, if you have questions, you can reach out to recruiters. They can answer a lot of your questions. They can give you all the like down low on like what the military can offer. And, if you're up for a interesting experience, it's definitely going to do that for you.
yeah. One area of nursing, just one of the thousands, you know.
Well, then, yeah, well, and it's just, I don't know, it's a unique experience, but it's really similar in a lot of ways. And I think a lot of people think like when they get into the military that nursing or medical care is 100% different. It's not. It's all really the same. It's just you do it while wearing a uniform.
Yeah. Awesome. All right, Corrine. Well, thank you so much for coming on today, and I will talk to you soon. That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubin and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.